Hello, and thank you all for attending. My name is Dr. Rick Kleinbart. I'm from Mercer-Bucks Orthopaedics. I'm talking to you now from our surgery center. That's our background. In honor of St. Patty's Day, I'm wearing my green. It is an Eagle shirt for any of you people that care or don't care. What I'm going to talk about at a high level is what are biologics, and what they are, and also how we're using them currently in orthopedics. I'll try to give you science as best I can in terms of what's known and what's known, what's proven and what's not proven. We'll talk about some of the stuff at the end about the details of how we do it and where we do it. And we can also talk a little bit about what's covered and what's not covered. So really, what are biologics? Biologics are just natural chemicals or growth factors in cells. They can come from two different places. They can come from your own self, that's called an autograft, or they can come from somebody else, and that's called an allograft. Specifically, what we use allograft tissue in lately is we are using fluid from a pregnant woman, which is harvested generally at the time of C-section, and that's called fluid flow or amniotic tissue. So how does everything work? And that's a good question. So there's two basically main types of biologics. There's PRP, and amniotic fluid is one group, and we'll go into it in a little detail. And then there's stem cells. So PRP stands for platelet-rich plasma, and I have a slide down the road showing what that is. But basically, platelet-rich plasma is a portion of your own blood which has concentrated platelets. And what these platelets have is they have growth factors, which we call cytokines. And cytokines are little messenger molecules. And basically, this is a very complicated slide, and you don't need to remember any of it. And the biology of this stuff is pretty complicated. There's at least 10 to 15 cytokines or growth factors in everyone's cells. And so what happens is normally when you're injured, that your body then sends out a signal saying that you have an injury. It then activates these cytokines, which then brings messengers to what's called mesenchymal or stem cells to bring repair tissue. And what we're trying to do with PRP or amniotic fluid is to duplicate that injury signal to make your body think that you recently got hurt or injured. And then by doing that, bringing the appropriate cells and repair tissue to the area. So the advantage or the goal of the cytokines is they have anti-inflammatory properties, which means they help control inflammation. And inflammation is a little misunderstood term, but what inflammation basically means, it's your body's response to a stress. And it has a good side, and the good side of inflammation is that it helps bring the right molecules to your system to get repair tissue. However, if you have too much inflammation, which is what happens in rheumatoid arthritis and a lot of diseases, you can also get damage to the tissue. So there's a good side and a bad side to inflammation. And part of what we're trying to do with PRP or amniotic fluid is actually to help control or regulate this inflammation. The PRP and some of the cytokines have been shown to have some regenerative potential, but it's small. One misconception I have for my patients is I had a gentleman who came in and I gave him stem cells, and for 5 years he had no pain in his arthritic knee, but he was mad at me for the entire 5 years because his x-rays never got any better. You have to understand where we are right now is that we have the ability to alleviate your pain. We have the ability to maybe get some regeneration, which we'll talk about later on, but we're not going to change your x-rays. This isn't the fountain of youth, and we're going to make your 75-year-old knees look like they're 20. That just doesn't exist. Amniotic fluid, which is in the same group, is basically usually 2 cc's of fluid that's taken from a pregnant woman at the time of a C-section. The fluid is then processed and it's injected into your knee. And we're going to talk about it a little bit more, but it works very much like PRP. It doesn't actually have cells, it has mostly growth factors. Now, the other major group is stem cells. Now, stem cells, what we're talking about, they have different variations. Some of them are called mesenchymal, which means they come from bone or muscle. or skin. And then there's other ones that are fat derived. And what a stem cell does is if you take a stem cell and you put it in a lab and you treat it with different chemicals, that stem cell has the ability to differentiate, which is a fancy word for change, into a specific type of tissue. So you could take a stem cell in a laboratory, and if you treat it for about 20 days with different chemicals, I can turn it into cartilage, I can turn it into bone, I can turn it into fibrous tissue, which is scar tissues. Other stem cells you can turn into lung tissue. The advantage to the stem tissues is they are also anti-inflammatory, but they also decrease your immune response. So they help in some of these inflammatory arthritis. And stem cells has been shown to be able to regenerate bone. That's been documented. It also has been shown to a lesser extent to regenerate some cartilage and some other tissue, but that evidence is much more inconclusive. So again, these are the three main types, and we kind of just talked about it. There's PRP, which stands for platelet-rich plasma, amniotic fluid, and stem cells. So what is PRP? Because PRP is probably the most common thing that people know about and the most common thing that's used. And it's used for both arthritis and it's used for tendon issues. So basically what PRP is, it's called the Buffy coat, and I have a slide of this. So what happens is you come into one of our offices, pretty much the Princeton office, or whether we're doing it in a surgery center, and we take out about 60 cc's of blood out of your arm. And then we mix that blood with anticoagulation so that the cells don't clot, and we put it in a centrifuge. A centrifuge is just a device that spins really quickly. And depending on what kind of PRP we want, because there's two types, there's regular PRP, which is used predominantly for tendons, and what's called PRP, which is pure, which has less cells, which is used for arthritis, and we spin it down, which means it goes in the centrifuge for 5 or 10 minutes. And then what you're left with is this little white coat that's in the middle, if you can see my fingers. And we take those little white coat, and we usually get anywhere between 4 and 9 cc's of fluid, and that's what's injected in there. The goal of the process and of almost all the companies is to get you roughly 7 times concentrated platelets, which would give you a huge amount of PRP, or platelet-rich plasma. The PRP is FDA accepted, but it's not approved. The way PRP works is that you put it in your body, and it's not like a cortisone shot. You're not going to get relief immediately. In fact, for a lot of people, they have more pain for a week or so from the shot. The platelets that are in PRP degranulate, which means they break apart at 7 days and at 14 days. And that's what we're trying to get. That's the normal breakdown of platelets that you see in normal healing. And what we're trying to do is duplicate that healing. So when you do a PRP shot, you're not really going to see results significantly for anywhere between 4 and 6 weeks. We're going to talk a little bit more about specifics when we get into just injecting tendons. All right, amniotic fluid. So amniotic fluid is new on the market. This is the only product, just so you know, if you have Medicare, is covered by Medicare insurance. You have to have straight Medicare. You can't have Aetna Medicare, United Healthcare. It has to be straight Medicare. But if you fail other treatment, this is the only product which is covered by insurance. And this is basically harvested from pregnant women during C-section. Originally, it was fresh frozen, which means they took the fluid fresh, they deep freezed it, and they were trying to preserve the cells. And what they found was so when they did this, they were basically trying to give you both growth factors and they were trying to give you cells, which is the best of both worlds. However, when they looked at the injections, none of the cells survive. So most people are not using the fresh frozen anymore. They're just using the processed one, which is a lot easier to deal with. When you used fresh frozen, basically I had 20 minutes to thaw it and I had 2 minutes to inject it once you were thawed. So I did a whole bunch of these, and we used to put people on the table, mark out their knee, numb them up, and then literally go, okay, we're ready, and run in there and stick them with the needle and leave. With the processed ones, there's no time element. The early studies show that there's 46 concentrated growth factors in the amniotic fluid. It can be used for both tendons and for arthritis. It has a better risk profile. There's a little less side effects from it. And it seems to work pretty well. But again, it's the same problem in that it takes at least 4 to 6 weeks for it to work. And then the last thing we'll talk about is stem cells. I use mesenchymal stem cells, which usually means I get it from bone. That's how I was trained, and that's what I'm comfortable with. One of my partners, who might or might not be on the line, uses fat, where they basically put a needle into where your fat is in your abdomen, and they process the fat, which also has stem cells. I think whichever the source of the stem cells, if you're doing your research, what you really want to look at is called colony forming units, or CFUs, because it's the CFUs and not the amount of cells that actually is what seems to correlate with doing well in terms of helping you. It's actually not that painful. I've done this as an outpatient, and we also do it in the OR. Typically what you do is you go in and you numb up the iliac crest, which is where your pelvis is, and you basically take a large needle and you hammer it in. It doesn't hurt as much as it sounds. And the technique I use, we take out 10 cc's, which has a lot of colony forming units. We mix it with a little bit of heparin. And then depending whether you're in the operating room or whether it's in the office, it's either injected straight or mixed with something else. And we'll talk about that in a little bit. But you can get stem cells from lots of bony places. The 3 most common places are iliac crest, which is your hip, the femur down by your knee, and the other part of your knee called the tibia. And that's the order for the best set. The most stem cells are in your iliac crest. The second best place is your femur, and the third best place is your tibia. I do not have much fat experience with fat. Dr. Kojo, who is hopefully on the line, who does it in our group, does do fat. And that's something you could talk to him about. All right, so what do we use stem cells for? Now, just before we get there, the biology of PRP and stem cells is really complicated. If anyone's interested in this, I didn't think it was for general talk, but if someone's interested, in the question and answer, they can give Jen or give me their email, and I can send you some stuff to go over it. But it's a really complicated biological cascade with a ton of growth factors, and it's not yet all been worked out, and I didn't think it was worth weighing down the detail. The most common reasons for doing biologics are tendinopathy and arthritis in orthopedics. And the areas where it's used the most are tennis elbow, the Achilles, sore kneecaps called jumper's knee, and rotator cuff. There is good study out there showing there's at least a 75 to almost 80% efficacy rate for tennis elbow, and also for one which I left out here, which is for the gluteus medius, which is if you have pain on the outside of your hip. It's actually been shown in the orthopedic literature that you would benefit from a shot of PRP versus cortisone for your tennis elbow and for your hip called the gluteus medius. So in our practice, we usually will recommend 1 cortisone shot because, again, there's a cost to this product. But if I will not give any more than 1 cortisone shot for tendinopathy anymore. If you don't get better, then we highly recommend that you go to PRP. In the Achilles tendon, which is where you have that bump or swelling in the back, or if you have jumper's knee, we don't use cortisone ever, and we only usually will treat those with PRP if you fail conservative management. Now, for rotator cuff disease, and it's not indicated for people that have a torn rotator cuff, but if you have a partial tear, or if you have what they call tendinopathy or tendinitis, PRP has been shown to be effective. It's not as good as the tennis elbow, but it's probably in the 70% range. And it's something that we highly recommend, or I use often in people that don't want to have surgery, but still have pain after they failed therapy, and 1 cortisone shot. And I mean 1 cortisone shot. Or the take-home lesson from this for everybody is you should not let whoever's treating you give you multiple shots of cortisone. The studies have shown after 3 shots of cortisone, you run a significant risk of rupturing your tendon. So we limit it to 1. It's just been shown not to do it. Also, it's been shown if you get a cortisone shot in like your tennis elbow or in your rotator cuff, you're not supposed to have surgery for probably 12 weeks because of the increased risk of infection and or a bad result from the surgery. The other use is arthritis, and all three products are indicated for arthritis, and it is not yet clearly defined whether one is better than the other because no one has yet done a head-to-head study. But I use most of my stem cells, almost all my stem cells on arthritis. I also use PRP on arthritis and amniotic fluid, but 100% of my stem cells go to arthritis. There is good evidence in the orthopedic literature that you will get 6 months or greater relief from 1 or 2 shots of PRP in your arthritic knee. So it is something that you can do to buy yourself a significant amount of time if you're not ready for a knee replacement. The data on this is pretty decent. And actually there's a recent study, and again, I don't want to get too technical, but there was a recent study which basically showed if you can keep the cost down to under $1,200, it's actually more effective than viscosupplementation in terms of pain relief and return to function. And that study was done, and that was pretty good. And it came into a cost-benefit ratio. But again, if you can afford it, it's worth it because it can alleviate your symptoms. I know you're not supposed to talk about yourself, but I have done PRP and amniotic fluid on my knees and my tendons. I have not done stem cells, and I have gotten significant relief from both products. I'm not going to tell you you're going to be pain-free, but I've been able to get my pain from, let's say, a 6 to a 3 pretty consistently, which for me is a win. So let's just talk about kind of how I'm using this in my practice. And this is sort of what people are doing. All right. So you come into the office and you have a sore tendon. So when you use the word tendinopathy, I'm going to talk a little biology, and I can't see any feedback, so I don't know if any of you understand or not, but I'm trusted. So tendinopathy to me is rotten potato. And what I mean by that is that you have a tendon that if you ever had a potato that's rotten, it's hard on the outside, but when you cut it open, it's black or brown on the inside. That's what tendinopathy is. Your tendon's made of millions of fibers, and the tendon's not torn grossly, but the inside of the tendon has lots of fibers that are damaged. And because of that, it's not working properly, so it hurts. And what's happened is every time you had hurt your tendon, you started to try to heal it. Nature will try to heal anything. And there's 4 phases to healing. And you got stuck at phase 3. It wasn't you personally. This happens to everyone. So you almost healed, but you didn't get there. So, and your biology, for whatever reason, wasn't good to get you to the hump. So the purpose of doing the biologics, and there is a component of mechanical irritation, is to make your body think that you just hurt yourself yesterday. And what we're trying to do is get you better biology by backfilling with PRP, stem cells, amniotic fluid to get you over the hump. And that's the theory behind this. So for tendon, what you do with a tendon is you usually do some type of percutaneous tenotomy, which usually just means you put a large needle in there and stick it, and that produces the mechanical irritation. Or you can do something formally where you put something that looks like a water pick to break up the tendon, and then you backfill it generally with PRP or amniotic fluid. In my experience, whether you pick PRP or amniotic fluid, there really isn't any difference. I personally don't use stem cells for arthritis, for tendinopathy. I haven't noticed it's worth the extra cost. When you do PRP for a tendon, we usually recommend 1 or 2 shots. The laboratory data shows that if you do 1 shot, the number of tendon cells go up 4 times. If you do 2 shots, they go up 10 times. So there is a theoretical laboratory advantage to try and do 2 shots if you can, because you get some synergy. I usually tell patients that we give them 1 shot, and we usually see them back at 2 weeks and 4 weeks. If at 4 weeks you're all better, you don't need a second shot. If at 4 weeks you got no relief, you don't need a second shot because it didn't work. If you're halfway better, then I think it makes sense to do a second shot. And that's the current protocol that we're using in our practice. For arthritis, you can use any of the three. The most common use one is, again, PRP. Amniotic fluid is very popular on the West Coast, where there's a couple 100,000 injections, which is why it's FDA approved. Stem cells, there's good data on it, but again, there's never been a head-to-head study. The current trend right now is combination therapy, if you can, again, afford it and I can get it approved. And what people are tending to do now is to do viscosupplementation with PRP or viscosupplementation with amniotic fluid. So what viscosupplementation is that it's highly uronic acid, which is actually used to be made out of a rooster's comb, which is the red part of the rooster's comb. Now it's made synthetically. And it's been in the orthopedic practice and literature for at least 20 years. And it works about 70% of the time to give you 6 months of relief. Probably most people who are listening to this talk have had visco with varying degrees of relief. There is a paper out from China, and it's actually a good study, where when they mixed viscosupplementation and PRP together, they got a synergistic effect and they got a significant improvement in people's pain. And they also got a significant improvement in people's biological markers or cytokines. There was a marked improvement of their inflammatory markers, which was the first really good science to show that the two of them work together. I have done some of it also with the amniotic fluid, which is called fluid flow. However, when you do that, you can't do the two of them at the same time. You have to do them a week apart. So the one thing that is somewhat controversial is, do you do them both at the same time or do you do them 1 week apart? And that's something that we can individualize if you like to treat that way. The other thing we've been doing that's a combination therapy is something we do in the operating room. So what we're doing is we're taking people who have arthritic knees, again, who don't want to have a total knee replacement, and cleaning out their knee. So you do a knee arthroscopy, and the success rate is roughly about 70%. It's not great, it's okay. But again, the studies show if you're one of those 70%, you can get relief for anywhere for 2 to 5 years putting off your knee replacement. And the data shows that 70% of the people that get their knee cleaned out for arthritis don't get a knee replacement for up to 10 years. So again, it's a personal choice. It depends on your disability and how much this hurts you. But what I've been doing is, if I do a knee arthroscopy, we have been doing iliac crest, which is from your hip stem cells, and mixing it with what's called hydrogel or a colloid. And what a colloid is, or a hydrogel holds the cells in place. So the stem cells tend to stay in your knee for a couple of weeks. The advantage to it is the data shows that you get much more bang from your buck because the cells tend to stay in your knee longer, which means they have longer to be worked on and to differentiate into the place you want them to go to. The downside of the hydrogel is that your knee stays swollen for a couple of weeks, and it can be pretty uncomfortable. And I warn everybody about it, but no one listens because they don't believe it'll happen to them. But for 2 or 3 weeks, you can be pretty sore because the hydrogel literally will suck up all the fluid in your knee. So you sort of get like this, almost like a blood, you sort of get like a hematoma or a big black and blue in your knee. And it takes a while for that to go away. So where do we do all this? A lot of this stuff can be done as an outpatient. PRP, amniotic fluid, can be done as an outpatient. They are usually done in our Princeton office because I usually do them either under ultrasound or x-ray guidance, and that's where we have a fluoroscopy machine. Additionally, if you're using PRP or amniotic fluid, you're considering manipulating tissue, and by the state of New Jersey, it has to be in a documented blood lab or certified blood lab, and that is our blood lab. We also do, if you don't like needles or you need to have anesthesia, we do them in the Mercer County Surgery Center, which is in our Lawrenceville office. It is a beautiful brand new building. I'm bragging now, it is rated the #1 surgery center in the state of New Jersey and 15th in the country. It is clean, it is beautiful. There is no COVID infections in here. There's never been an infection in here. And so we do a fair amount of the stuff also in here because we have fluoroscopy and ultrasound. And if you wanted to do something here, because some patients want a little anesthesia or sedation and they're uncomfortable, having someone put a needle in their hip. basically in an office setting. So that's a really kind of high level overview of what PRP biologics are in my practice and the general state of the art in the literature. I'm going to now just open it up to anybody who has any questions. The only insurance company currently that we're getting any success getting this covered with is straight Medicare. Again, they cover amniotic fluid. Sometimes if we're doing stem cells in the operating room and I am mixing it with some of the colloid, I can get it covered, but that's a case-to-case basis. So if it's something that you are interested in doing, normally what we do is we bring you in, we do a consult, I know forever. And then we usually get it through that. We try to, Denise puts it, who's my assistant, through the pre-cert to see if we can get it covered. We are working on with the companies, trying to get the commercial insurance companies to start to pay for some of these products. So far, it's been a little bit of a hit or miss. So I don't want to say yes or no, but again, if you're interested, it's worth popping in, just to talk about it and see if we can do something on a one-on-one basis to make it work. We've had, it's like 50-50. That's the best I can tell you. So the next question is, how young of a patient have you done PRP on? The youngest person I've done it on was 17. And it was someone who had jumper's knee, which is sore kneecaps just underneath it, in a baseball player that would not get better from, non-operative treatment. So there isn't really an age limit as far as I know. There is some limitation for, if you're listening, if you've had cancer, especially if you've had bloodborne cancers like leukemia or any of those kind of stuff. A lot of times the hematologist will not let us, you definitely can't do stem cells. Sometimes they'll let us do PRP. There is some small theoretical concern that when we process your stem cells, we trigger them to be abnormal. It has never been reported, but it is something that if you do have a history of cancer or some type of blood disease, we usually ask that you talk to your hematologist first. And that's part of when we do the, history and physical.
Dr. Kleinbart, it looks like TNF is tumor necrosis factor.
So the answer, let me type. So I didn't really want to get into the weeds very much about whether it was tumor necrosis factor alpha or beta. The answer generally is yes. If you look at the papers and the biology or the biochemistry of this, it seems to be that you get across the board modulation of growth factors, including TNF, from PRP injections and from the amniotic fluid. No one has done a paper that's isolated something that says that PRP is better for tumor necrosis factor alpha or beta. That I haven't seen in the literature. So, and interestingly, when I used to be an academic guy down at Hahnemann, which no longer exists, we used to do this. What we did is, before we would inject you, we used to drill fluid out of your knee, aspirate that fluid, send it to the lab, and look at your cytokine profile. Then we would treat you and re-aspirate your knee to see specifically what we did. And so no one's yet documented that on an individual medicine basis. That would be the perfect way to go. Because then if it turns out that your knee is related to TNF, your pain's from TNF alpha or beta or interleukin 1 or 6, and I gave you a specific antibody just to that molecule, then I could pretty much get rid of your pain, or at least your biologic pain, with a minimal amount of risk or side effects. That science isn't there yet. I apologize. I wish it was. I'm just reading down the list. Are there any procedures performed at the Bucks office? You mean Langhorne? No. Generally, the answer is not, mostly because we just have everything to set up and process the blood products in the Princeton office. You're not there very long, and it's not a terrible ride. It's just everything's set up to do it better there, you know, and for me especially, I use fluoroscopy. So and we have an ultrasound machine there. So I make sure we're in the right spot. And here, the next question, would PRP work for the Achilles tendon? The answer to that is yes. It's just not as good as tennis elbow, jumper's knee, or the gluteus medius. I probably have at least over 10 people, if not more, done on the Achilles. And a lot of people have done very well. It also works really well on, it works pretty well on plantar fasciitis. The problem with the Achilles tendon is it's very dense. So it's hard to get fluid into that area adequately. And if you're really sore with that, a bunch of those we have been doing, that's one of those where sometimes we'll do an associated procedure called TenJet, where we go in with a little thing that looks like a water pick and debride the tendon first and then backfill it. But that is something that we do use it on a regular basis. Next question is, can one go back to active tennis after having your knees treated? My answer is yes. I'm not going to stop you. Look, the purpose of doing any of these procedures is to make you active. If you're treating someone who has an arthritic knee, I'm not going to reverse the arthritis. What I'm hopefully trying to do is make you pain-free or pain-reduced for 6 months or longer, which would give you an opportunity to lose weight if you need to, rehab your legs so you get stronger, and then go back to your normal activity. The next one says PRP versus surgery, but PRP versus surgery of what? I don't know what you mean, surgery versus surgery. It depends what you're getting surgery for. If it's for the last topic we talked about, my answer to you is I would always try, operating on someone's Achilles is a long rehab. If you've got Achilles tendinopathy, you usually have a very painful bump and a thickened tendon. So the way that's treated surgically is you have to make an incision and you have to debride at least half of the tendon. And it takes at least 3 to 6 months to recover. So for that, especially because that surgery is such a long rehabilitation, I would usually tell my patients to consider biologics and or percutaneous tenotomy first, because if it works, you save yourself a long recovery. So that's how I would make, again, it's an individual decision, but based on if it's that surgery, I would do PRP if it was my Achilles, just because the rehab is so long. The last question says, I have primary lower extremity lymphedema and I'm avoiding knee replacement. Which procedure would you recommend? Truthful answer, I probably have to, I don't have any experience in the face of lymphedema. So whoever sent this question, what I would actually ask is that in terms of your knee, I would probably tell you that I would do visco and PRP. It's probably the most reasonable cost price so far. I know there's no contraindication between lymphedema and the visco supplementation. I don't know if there's any interaction between the platelets. I don't think there should be because they're in your joint, but if you were going to go that way, I would do my homework and do due diligence just to look it up, because I don't think there's a contraindication, but I have no knowledge or experience between lymphedema and PRP. They do use a fair amount of amniotic fluid and amniotic membranes on wound healing, which we didn't get into. So there might be something in the wound literature about lymphedema and one of the biologics. I just don't know. So before I answer it, I would probably just do my research and see if there is, because if there is, then maybe there's one product that would help you for both. Is anyone working on a meniscal replacement? The answer is yes. A meniscal replacement's been around for years. There's 2 or 3 different techniques for a meniscal replacement. Basically, it's something you need to get worked up. It depends on what the rest of your knee looks like. It depends on your age. It depends whether you have arthritis in that compartment of the joint. And typically what happens is you CAT scan your knee. They then send it down to the place where they acquire the tissue, and you get a meniscus from another person called an allograft, usually with bone plugs. And it's usually a combination of arthroscopic and open surgery to replace your meniscus. They have a decent track record. They have a track record going at least 15 years, if not longer. And the results are in the high 70s, mid 80s, depending on who you read. So it is something that is out there. And if you're interested, it's doable. Again, it depends on your age, the amount of arthritis, plus also the amount of arthritis in your whole knee. There's 3 compartments to your knee. Medial, lateral, and anterior. And you technically can't have a lot of arthritis in either of the other compartments, or it's not worth just putting in your meniscus. And you also have to have normal alignment. But again, that's something you'd have to come in. We'd have to, or whoever you're talking to has to get a standing x-ray. You need a bone scan. You need a bunch of stuff done just to see whether you qualify. The last thing was about cost. I don't ever like doing cost on the phone, being truthful. So what we're talking about, basically PRP runs about $750 to probably the extreme of stem cells, which run about $2,000 roughly is the ballpark for it. And again, the prices sometimes vary depending on what product you pick, whether we have to mix it with a colloid or we're doing some other procedure. And also it depends on the joint, not for the PRP, but some of the other things we mix with are covered by insurance in certain joints, but not others. So it is something that you want to talk about and just see what we can get covered and what we can't.
That sounds great. Then we will let you go so that you can start with your afternoon patients, Dr. Kleinbart. Thank you so much for taking the time to educate all of us on biologics. I know it's a confusing and interesting topic, so I do appreciate your time to let us know all about it. And then if anyone in the chat or anyone who has been on the presentation has any questions, Dr. Kleinbart and I will be happy to get back to you. If you could just email programs@mbortho.com, then I will be sure to get that information to Dr. Kleinbart. He will answer the questions and then I will get back to you. Again, that email address is programs@M as in Mercer, B as in Bucks, Ortho, ORTHO.com. Thanks again, everyone, for joining us. We hope you enjoy the rest of your afternoon and evening and have a great St. Patty's Day.
Thanks, everybody.